Okay. Good day, everyone. I'm standing in for Tom Farden, who can't be here. We're really lucky to have John Irving, one of our interventional cardiologists, speak today. I'm a simple physician, and occasionally I read articles in the Lancet saying, do a CABG for coronary artery disease, or do PCI, and then it changes again, and I still don't really understand. So John Irving is going to reveal all about left mainstem disease. Thanks, John.
Okay. So when you heard that there was going to be a presentation on a media scandal in cardiology, I'm sure you all thought of this Daily Record fearless expose of the fact that NHS Tayside was a little slow in responding to a Freedom of Information request about temporary facilities, and illustrated it with a picture of our state-of-the-art cath lab shed, Lothy modular device. But there was a bigger thing.
This is a story about fights and controversy in the medical community.
It was never discussed with me. It was never discussed with me.
About a clinical trial that failed to publish some of its results.
The knowledge of that information would, in my personal opinion, make a genuine and substantial contribution to our ability to appreciate the nuances of the results and the inconsistencies that are observed.
Data that doctors think should have been published.
To appear to claim there was no difference between these two groups, I thought was dangerous for patients.
Results that change the guidelines that doctors use to treat your heart.
They are unsafe as they stand. This is not a robust and safe recommendation.
So, very dramatic. Left mainstem coronary artery disease. This is a coronary angiogram. Here's the catheter that we've floated up from the radial artery. This is the left coronary artery splitting into the LAD, circumflex, and the left mainstem is this segment here, and there's a tight lesion just there. Sometimes as much as 80% of the coronary blood flow is downstream of the left mainstem, so if somebody's got a tight lesion there, they will have angina very readily. Typically their symptoms will come on at about 3 minutes of the Bruce protocol, which is a very, very slow amble on the treadmill. And this near complete blockage, if it blocks altogether, then that's extremely dangerous. That will be good night Vienna. And for 50 years this has been managed by coronary artery bypass graft surgery. And just to remind people who don't think about this very often, these are the coronary arteries. The surgeon will access the heart through a median sternotomy, splitting the sternum, obviously under general anaesthetic. They'll harvest vein from the legs. They'll harvest the internal mammary artery, generally the one on the left, from inside the chest wall. They will put the patient onto cardiopulmonary bypass to maintain circulation while the heart's stopped. They'll look after the heart with cardioplegia, and they'll anastomose the new blood supply onto the coronary arteries. They'll reverse the process, warm the patient up. They'll be in ITU overnight and often up to about 7 days in hospital, 2 or 3 months off work, recovering, and then feeling very much better. It's never been a cure. There's always been the risk of graft disease, typically 8 to 10 years further on. How effective is it? Well, this is one of the early studies from the 1970s. So bypass grafting was essentially invented in 1968. The group in the Mayo Clinic published the results of 50 cases where they'd managed to reliably revascularize patients with severe angina. And this is an early report from the Veterans Administration randomized trial of coronary artery surgery. And if you had left mainstem disease, it's not a huge number, but that's the surgically treated arm, that's the medically treated arm. So survival, all-cause mortality was much worse in the medically treated arm, up to about 3 years. And after about 3 years, once they'd analysed this study, people stopped being randomised when they had left mainstem disease because clearly the outlook with medical therapy was really poor. It's quite interesting looking at the details of the study. Patients got angina more than half of them got angina during sedentary activity. They were getting angina four or more times per day. A lot of the studies that you might hear about now, people are typically getting angina once per month because these are the people that can be randomised. A lot of them it came in a sort of peri-infarct fashion. And when you looked at the different tertiles, actually you could identify people that were at low risk, where medical therapy did better than surgery. So people who presented in an entirely stable fashion, perhaps with less severe left mainstem disease that actually may not have been flow limiting. When you look at the high risk tertile, by 6 months, nearly half of the medically treated people are dead, and there's further deterioration. So clearly left mainstem in some patients is highly dangerous, and revascularization is exceptionally effective. Bypass surgery has always been a big deal. If you look at all comers, you look at a death rate of 1 to 2%, stroke rate of 2 to 3% in the perioperative period, MI rate, and we'll talk a lot about definitions, but grafts occlude distressingly readily. At least half of people will get at least transient atrial fibrillation in the course of their perioperative period. Infection can be really nasty. Cognitive impairment is often very subtle, but sometimes is life-changing. People have regular problems with the sternal malunion, renal failure, and failure to recover. What's really striking is that a spell in intensive care is a real challenge for many individuals, and post-traumatic stress is reported in, depending on how you define it, 20% of patients, and often people are diminished after such major surgery and never feel secure again, and that's very disappointing. We may have saved their life, but we've changed it irrevocably for them. It's never been a cure. This is a big study, again, from a different Veterans Affairs group, looking at graft occlusion. So when you leave hospital, about 10-12% of vein grafts have occluded because the surgeon's been ambitious and they've tried to stitch it onto a very small target. Perhaps it's kinked, they've had a thrombosis. Some of this is silent because actually the lesions were not entirely flow limiting, and there's maintained flow down the natives. But there's early loss of grafts, late loss of grafts, and while it seems to stabilise in this study, the numbers were very small, and actually around about 10 years we see a very significant loss of grafts. So bypass surgery is not a cure for coronary disease. And now there's this. This is Andreas Grunzig's fourth patient. Procedure was done on the 24th of November 1977 in a 43-year-old man. He had a severe left main stem lesion. Andreas Grunzig used his homemade balloons that he'd built in his own kitchen, dilated the stenosis with a fabulous angiographic result. But that patient died suddenly about 12 months afterwards. Balloon angioplasty was handicapped by restenosis, that the vessels would recoil, and if you've got recoil in the left main, then that might be associated with sudden death. And angioplasty was never really mainstream for left main stem disease. Stents were invented, but bare metal stents restenosed. Up to about 25% of patients would get symptomatic restenosis because scar tissue formed in stents. Briefly, in the 1990s, brachytherapy was tried, where we put radiation emitting catheters into the stent to treat the vessel so it wouldn't restenose, but that doesn't work. And then drug-eluting stents came along. This was the first study, simple lesions, but restenosis, 26% in the bare metal stent, 0% in the drug-coated stent. Revascularization, all the lesions that restenoze were revascularized, 0% in sirolimus. Event rate, MACE-free, 73% in bare stents, 97% in Ravel. So clearly, we've now got stents that work reliably and have a good long-term result. Coronary disease, like rust, never sleeps. So in the background, silently, plaques get bigger, and then you get a plaque rupture, and you get an acute event. We try and reduce that with secondary prevention, but we don't eliminate it. When the surgeon has plumbed his graft on to this part of the coronary artery, you can have as much disease progression as you want, but if you've got a good graft with the flow coming here, you're not going to have a big myocardial infarction because the flow is going to come down the graft. When you've put a stent in the left mainstem in the proximal part of the vessel, actually it would be that one there in Da Vinci's dissection, you've treated that bit and you may have a low event rate in the stent, but all of the plaques in the rest of the vessel can potentially progress, potentially rupture, potentially cause events. So there was great enthusiasm for drug-eluting stents. There was potential for equipoise. Perhaps drug-eluting stents were going to replace bypass surgery, and this was the first big trial of drug-eluting stents versus surgery in complex disease, published in 2009, Syntax trial, sponsored or paid for by Boston, a stent manufacturer, but delivered by cardiologists and cardiac surgeons. Looked at that with drug-eluting stents. International study, all patients with complex disease were considered for the trial, and a very high proportion were enrolled in the study. They had to go through a heart team, so a multidisciplinary meeting where surgeons and interventionalists would review the angiogram and decide whether a patient could actually be treated with both treatment options or whether actually only one treatment approach was viable. This is 15 years ago. These patients had disease that was too complex to treat by angioplasty. These patients were too frail to treat by bypass surgery. But a significant proportion were randomized equally to bypass, and in this trial, the Taxa stent, stratified according to left main and diabetes, because these are likely to impact upon it. So people in late middle age, mostly men, a significant number of patients with diabetes, but mostly stable patients. So the patients we treat in the cath lab in Dundee and around the UK is about 75% with acute coronary syndromes, either STEMI, non-STEMI, but this is a trial of chiefly stable patients who are at low surgical risk. It was complex disease, so 2/3 had left main stem disease, 1/3 involved, 3 vessel disease not involving the left main stem, 1/3 had left main stem disease and various other bits of disease. A quarter had a complete occlusion, and 3/4 had total bifurcation. So complex disease requiring complex procedures, and they knocked themselves out. They put nearly 5 stents into each patient on average. Our average is 1.3. They put 90 millimeters of stent in, and one enthusiast managed to squeeze 324 millimeters of stent into one patient. So this was a big trial. This was complex disease, and what were the outcomes? At 5 years, so I showed you the 1 year outcome, which was the initial endpoint. When you look at all-cause mortality, you did slightly better with bypass surgery, but it's not statistically significant. When it came to stroke, you did slightly better with stents, but again, not statistically significant. When you looked at myocardial infarction, it was clearly better with bypass and statistically significant. When you put it all together, there's a slight 4% difference in all comers at 5 years, showing that bypass surgery was still superior to drug-eluting stents at that time. Now, when you look at the left main alone, it's a slightly different population. It was specifically selected for. The differences were not as large. When you looked at death, actually the stents seemed to do a bit better, stroke clearly better, putting it all together, overlapping. So if you've got less disease, then it may well be that just because it's in the left main, it may well be that actually you do fine. And our techniques are improving. So from 2005, we've got better drug-eluting stents, they've got better polymers, got thinner struts, they're more flexible, you can put them where you want them. There's a better range of sizes that match the left main stent, which is often quite big. We're better at doing angioplasty, we get the size right by using intravascular imaging. We can get the stents wherever they need to go. We can now open up blockages most of the time. We've got stronger, more effective antiplatelet drugs, and there's less bleeding because we do it almost all from the radial artery. So as soon as the Syntax study had reported, the Excel study was designed and started recruiting in 2010, first published in 2016. So stents or bypass surgery for left main coronary artery disease.
The trial will look at different outcomes, and in this specific trial, it was death of patients, heart attacks, or the risk of a stroke.
Okay, so that's Professor Taggart, a surgeon in Oxford. And with all these big studies, you tend to use combined endpoints because there's more than one thing that might happen that's bad. And also when you've got combined endpoints, you don't need as many patients in the trial as if you were just to look for a single endpoint. And this is the results at 3 years for combined death, stroke and myocardial infarction. And there's no difference between the surgical group and PCI group at 3 years. There's initial excess in the bypass group, which you might expect because it's a bigger, more invasive procedure, but the gradient's a bit flatter with bypass, and the initial advantage of PCI is gradually being eroded as time passes. And that was the main outcome of the trial, so that's not very controversial.
So in other words, how likely was it that the patient would have a stroke, heart attack or die in the years following the procedure? 3 years after the patients had the operation, the trial researchers, led by eminent Dr. Greg Stone, published a paper with their findings. It said stents and open heart surgery were as good as each other. It may surprise you to learn that there's more than one way to measure a heart attack. When they were setting up the trial, the researchers said they would measure 2 definitions. The most commonly used one is called the universal definition and uses both blood tests and a heart monitor to see if someone has had a heart attack. The other, favoured by the researchers, uses just a blood test. There's debate around which is a better measure. Once you say you're going to measure something in a clinical trial, you are expected to publish it. In this trial, the researchers said they would show the results for both definitions, but they omitted the universal data. Okay,
so this is the first question that the Newsnight raised. So what is an MI these days? The World Health Organization, that I learned when I was a medical student, you had to have 2 from 3 of symptoms suggesting a heart attack, a rise and fall, a characteristic change in cardiac enzymes, and ECG changes. If you had 2 out of 3, you'd had a heart attack. And this situation has been complicated by troponin, and we could have hours and hours of discussing the meaning of troponin in the blood. And I'll just summarise it and say that it's detectable in many states of health, and we can perhaps move on. And it's an ongoing project to refine the definition of myocardial infarction. It's not set in stone. And Excel was designed when the second universal definition was live. The third one came out, so that definition changed, and we're now on to the 4th definition. And we'll go into in a bit more detail.
Newsnight Newsnight has been leaked those unpublished data, and the results are dramatic. In the definition of the data that were published, around the same number of people with stents and surgery had heart attacks. But in the unpublished universal definition data, around 80% more patients with stents had heart attacks than those who had surgery. When we challenged the people behind the trial, the company Abbott distanced themselves from how the study was conducted and published. They directed responsibility to the investigators. The investigators told Newsnight we'd been sent fake information, but experts we've spoken to said the data are credible. Okay, so now it's getting murky. Abbott distanced themselves from how the study was conducted and published. Well, that's very clear. Abbott paid for the study, but the study was done by independent research organisations, and that's the way it's organised. If Abbott were responsible for the data, then everybody would criticise it because they're clearly biased because they manufacture the stents. So Abbott did the right thing. They said, well, look, we paid for it, but it was run entirely by academics and through these trial organisations. 80% more MIs with universal definition. That sounds bad. Leaked information, described as fake information or credible information, neither of which particularly tells you whether it's true information. So the primary endpoint was defined in the study protocol. The way it was defined was in the study protocol, and it was consistent in the study protocol. Professor Taggart has claimed in various meetings that the definition changed, but he no longer claims that. So there was a definition of myocardial infarction used in this particular trial for a very specific purpose. The universal definition would require measurement of troponin, and that was optional. And not every centre collected it. And in fact, the majority of patients did not have troponin data collected because in all trials there's a huge amount of activity goes on, but not every single data point is mandated to be collected. So this is the periprocedural MI in the universal definition, and they're different. So it's arbitrarily defined, and it's not been tested against specific thresholds for looking for where harm starts. It's defined arbitrarily as a rise in troponin greater than 5 times the 99th percentile in PCI, but it has to be 10 times in patients with coronary artery bypass graft, plus some other evidence of myocardial infarction. As I said, it's not actually been correlated with outcomes, and it's much more feasible to establish in a cardiology unit if somebody's got an ECG changes than it is in a cardiothoracic ITU. And when they were designing the study, they looked for state-of-the-art definitions that would mean that myocardial infarction, if it had occurred, would be detected equally likely in the bypass graft patients as in the PCI patients. So this was their definition. If you had CKMB, the older-fashioned, less sensitive cardiac enzyme that reached 10 times the upper reference limit, that was an MI. Or if you had intermediate rise with other evidence of myocardial infarction, then that would count as an MI. And in this study, they looked at their definitions. So if you had a small rise in CKMB, then it didn't impact on survival. If you had 10 times the rise, then cardiovascular death was significantly higher. So they have validated their endpoint in their data set and note that specifically to minimise ascertainment bias. And Professor Taggart, who's getting a bit upset that the universal definition hasn't been published yet, was an author on this specific paper.
Okay, so myocardial infarction may be a bit uncertain. We know that everything, death and taxes is certain.
Earlier this
so let's
year,
think
the
about death.
investigators published another paper about what happened 5 years after the patients had received the treatment. It said there was no significant difference between stents and surgery. One of the senior doctors who'd worked on the trial from the start was based in Oxford, and he had severe misgivings about it.
I found the most concerning thing about the presentation of this trial was that if you look at mortality, deaths of patients at 5 years, there was a clear excess of deaths in the patients receiving stents. For every 100 deaths that you might have in the bypass group, you would have 135 deaths in the stent group. So that's a big difference.
And he's quite accurate. This is the death from any cause at 5 years in the XL trial, published last year in the New England Journal. There's a statistically significant difference between death in PCI and bypass of about, absolute difference of about 3%.
When you consider that these were relatively young patients, 66 years of age, and had relatively low to intermediate severity of disease, I think this was an extremely alarming signal. Okay, well, death is important, but sometimes it's not as simple as you'd think. So, death rates. We all know that this prototype fell down, but actually, these numbers are incorrect. These numbers are the numbers of the deaths during construction. So 75 men died during construction of the fourth rail bridge, and nobody died during construction of this initial bridge from its lightweight basis. 58 people died when it fell down, and 14 people died in the reconstruction of the current Tay rail bridge. But actually, if you judge bridges by mortality rates, the Tay bridge is better than the fourth bridge. I'm going to take that metaphor any further, but simple death rates, perhaps it's not always as simple as that. So this is the definition of death in the XL trial. Death will be due to cardiovascular causes, non-cardiovascular causes, undetermined causes. Cardiovascular death includes things that clearly happen to the vascular system, but also bleeding, which is interesting. Non-cardiovascular death is when people have clearly died of something else. An undetermined cause of death, when it's not clear exactly what the sequence of events is. And for this trial, all deaths of undetermined cause will be counted as cardiovascular. And this is the death rates at 5 years, again, from the paper from last year. So death from any cause, yes, different between the two groups. That's angioplasty, that's surgery, that's the odds ratio, and that's the confidence limits. But if you look at the non-cardiovascular causes, 18 more deaths. So this is patients who've clearly died of a different lethal condition, cancer or pneumonia or something like that. So more than half of the excess is due to things that were clearly nothing to do with whether they had stents or surgery. And definite cardiovascular and undetermined, well, the numbers are much smaller. So would there be a statistically significant death to difference in death? Is this due to the biological effect of the trial? Well, I'm not so sure.
The journal told us it met their standards, but Professor Taggart took his name off the paper.
Effectively, I have no choice. If I had left my name as an author on this paper, I would be effectively supporting the trial findings and conclusions. And I could not do that because, to me, the mortality data was so strongly in favour of bypass grafts that to claim, or to appear to claim, there was no difference between these two groups, I thought was dangerous for patients.
Okay, well, he makes his views very clear. He was upset that the death rate was not given due prominence in that paper of 5 years. This is the first page of the paper. Death from any cause occurred more frequently in the PCI than in the CABG group. This is the results section, looking at the death from any cause, and this is the discussion with a long paragraph of discussion about the interpretation. And Professor Taggart is an intelligent man who knows a lot about the data on bypass surgery and intervention, and knows that there's a lot of different context to consider. There was another trial running at around about the same time, the Noble study, sponsored by different stent manufacturers, randomizing patients with pretty much the same disease of the left main and a little bit of other coronary disease, and half of the patients had surgery and half had angioplasty. And in this trial, at 5 years, the combined endpoint seemed to favour bypass surgery. That there was a clear excess of events in the PCI arm after an initial excess in the bypass arm. And how did that break down? Well, actually, all-cause mortality was no different. There was a clear excess of repeat revascularization, so people generally coming back and having more angioplasty, more myocardial infarction, and a slightly unexpected late excess of stroke risk that is difficult to explain unless it's due to the fact that more patients in the bypass arm are having atrial fibrillation and getting anticoagulated, and more patients in the angioplasty arm are on dual antiplatelet therapy and then not getting anticoagulated. But this is an unexpected finding. So that happens in modern studies. So if you're looking at death, still a relatively rare event, a better way to look at it is in a meta-analysis of all the randomized trials of drug-eluting stents versus surgery. And this has been done and has been published, and there is no statistically significant difference between bypass surgery and angioplasty when you put Excel and Noble together with Syntax and another older trial called Pre-Combat. So that signal of death in Excel seems to be an outlier. Perhaps it's early that the event rates are getting worse with angioplasty as they have more restenosis. And here's the 10-year results from Syntax published in the Lancet last year. And yes, again in Syntax, as we discussed earlier, if you had 3 vessel disease and a lot of atheroma, on the whole you did a bit better with bypass than stents. But if you were in the left main stem group, actually you did better with stents than surgery. And diabetes was actually not a predictor. So a lot of the things that we think we know are perhaps not true, and that's why we do studies, to try and find these things out. So, for left main stem disease, what do we do? Contemporary trials of the 2 complementary, competing revascularization techniques show similar long-term survival in meta-analysis. The more invasive treatment, if you have bypass surgery, is undoubtedly followed by fewer repeat MIs and fewer repeat revascularization procedures. But, most of our patients are not the stable patients who tended to be studied in the randomized trials. Most patients are actually unstable and are a different population to those that are studied. Now, this is another outlier trial, but 142-day wait for bypass surgery isn't a mile away from what the current waiting times are in Scotland. And in Brazil, the death rate was 11% waiting for bypass surgery. That is a high outlier, but there is quite a lot of it's quite an attractive idea. Well, actually, we'll maybe put a stent in, and then if it restenoses, somebody can have a bypass, and that's a safer way of progressing for some patients. But we're all signed up to the decision-making process where there's an MDT discussion on the technical factors, how suitable is a patient for either revascularization technique, and then individual patient factors should determine what's best for them, and that's what realistic medicine says. MDTs used to be that the surgeon would make up his mind, and we'd just say, right, thank you. And now it's much more of a team effort, and results are determined by discussion, and that's how it should be. I'm going to conclude with the conclusion from the Newsnight report.
What do you think it tells us more widely about the way these clinical trials are conducted?
Well, throughout the course of the film, there were questions raised, and it was clear there was a big debate in the medical community about relationships between clinicians and researchers and these big medical technology companies. Now, there's one school of thought that says these financial relationships are vital for driving forward innovation, and that's how scientific progress is made. And there's a real public interest in this. But there's another school of thought that says, you have to be careful here. We have to make sure these relationships are carefully managed because of potential bias, either conscious or unconscious bias. Now, in our Excel trial in the film just then, all 4 of the main investigators declared they'd received personal fees from industry, 3 of them from stent manufacturers. 1 of them, who'd worked on the trial, then went on to play a significant role in writing up the guidelines, then went on to work for Medtronic, which is a big US stent manufacturer. Now, by our count, half of the people on the clinical trial, the investigators on the clinical trial, declared personal fees from stent manufacturers, and 1/3 of those on the guidelines task force, so the people writing the guidelines. 1 of them on the guidelines task force had even declared he'd received license fee payments for patents on stents. Now, all this is within the rules, but it does feed into a much bigger debate around these conflicts of interest and financial relationships between these big stent manufacturers and clinicians, particularly if it has an impact on patient safety.
Deb, thank you.
Okay, so this is their last swipe at the medical profession. I thought perhaps now would be a good time to declare my own conflicts of interest. I've not got any conflict or any fee to declare from this talk. I've done this out of the for the joy. I work on industry-sponsored trials and recruit patients into trials, and I 1 PA per week, so 1/12 of my work is paid for in that way. I do proctoring, so I teach colleagues on very complex chronic occlusion procedures, and I do that a few days a year for a device distribution company. I have sat in the last year. I've sat on advisory boards for Abbott and Novartis, a pharmaceutical company. I occasionally speak for Astra and Medtronic, and that all adds up to, in a really good year, 5% of my salary. I know some industry leaders who undoubtedly double their salary from this sort of activity. I mean, the main bias I have, obviously, is that I'm an interventional cardiologist, and that I put stents in for a living, and I think that's the best way to make people better. So, progress versus conflicts of interest. What do I think about it? Well, I think about what cardiology was like in 1995 when I was in SHO, and I can remember several patients who died purely as a result of one single plaque rupture. They were in late middle age, they didn't have anything else wrong with them, and they'd come in with a myocardial infarction, and thrombolysis had done nothing, and they died. And what attracted me to interventional cardiology was that actually you could treat people. And these days, all of those people would be treated in 5 or 10 minutes, and they'd go on to have 10 or 20 years of good quality survival. And would we have had that progress in an alternate universe where medical device companies were not commissioning advice from experts or sponsoring education or paying for these large trials? I don't think so. I think we'd still be listening to public health doctors wittering on about vegetables. But that's my point of view. Can we trust industry-sponsored trials? We know that industry-sponsored trials are more positive than other trials, and that's because they're very well designed, with very carefully chosen comparators and very carefully chosen endpoints. And if you compare Noble and Excel, which were both industry sponsored, the main difference is if you analyse them in the same way, you'd get exactly the same result in terms of perioperative events versus later events. And so actually I think it just shows that, it depends how you measure things. Is the data compromised? Which is what Professor Taggart has been insinuating. Well, the amount of effort that goes into audit and checking, the quality and extent of the conspiracy that you'd have to have fake data that's published in the New England Journal of Medicine would be world class. I don't think that's possible. It's the same way as people think the moon landings were faked. You'd have to have thousands of people, none of whom give away the secret. So I don't think that's credible at all. Is the Newsnight report healthy debate, a healthy insight into potential medical controversies, or is it factional mudslinging? Well, I'm not going to tell you my view. I think you can probably guess it. I think in the end, you have to trust the process. In the end, not everybody can be in the room where it happens, where it all gets sorted out, and some things need to be kept in the room where it happens. And that's all I want to say. Any questions?
Thanks very much, Dr. Irving. Any questions? So I've got one up here.
Thanks, that was really interesting. Just a couple of points and questions. I guess the first is the extent to which these types of clinical trial don't really reflect real life, and the kind of desire to have the really pure trials and how useful they are. The other thing you didn't mention at all was cost, and I wondered whether you think cost is important, and what are the relative costs of the procedures?
Okay, dealing with costs first of all. I was intrigued that the tariff in England for bypass surgery is considered to be less than the cost of doing bypass surgery. And the cost for angioplasty is clearly profit generating for hospitals. So there's been a clear political effort in England to increase the capacity of angioplasty because that's more effective for the greater numbers. So bypass surgery is about, it's all about arbitrary really. You've got you either have a unit and you pay for it and have a certain number of procedures done, or you don't. But bypass surgery is about £12,000, and I've tried really hard with complex angioplasties, and I've never got more than 3, 4. So bypass surgery is more effective, and I think it's not really a case of cost effectiveness. I think if you select patients well, you can get patients who will get a 20-year result from bypass surgery, that they've got good targets, they've got low peri-procedural risks, and they do extremely well and don't have any bother for a long time. But that's a very small minority of the overall population. And, nobody's arguing that there are some people who are better treated by bypass, so there are some people who are clearly better treated by angioplasty. We're kind of just debating where that margin lies, and both procedures definitely still have a role. The other bit of context is, of course, that percutaneous aortic valve replacement is now being shown to be at least as effective, at least in the short term, as surgical aortic valve replacement. So if both those are the bypass and surgical aortic valve replacement are the mainstay of cardiothoracic surgical practice, and the percutaneous options are now definitely in the same ballpark on the whole, and that's an important context. So there's a demarcation dispute that's going to happen, and my personal view is that Scotland has 3 cardiothoracic units and would manage perfectly happily with 1. But again, that's my personal view.
Other questions? I've got one. Also vegetables are good for you.
I don't disagree, but
for posterity on the video. No. The question was: what do you think David Taggart's motivation was here? Was this the last cry of a dying breed of dinosaur surgeons, or do you think he had and bearing in mind that the Oxford Cardiothoracic Unit has had its own problems in the last 20 years, and that's been well looked at? Do you think this was a real concern he had, or was this? What was the agenda?
I must admit, I've made an effort to not make any personal criticisms.
No.
I don't know him. I've never met him. I've heard second-hand reports of about him, which are again, best kept in the room where they're reported. I think he's given I think he's cherry-picked the data, and I think that's what I've tried to show in the talk.
And given that, as you say, most of the interventional work here is acute, and that's the same across Scotland, I would have thought.
Mm-hmm.
But with your chronic stable angina patients, then, how many from Dundee or Tayside are going up for coronary artery bypass grafting? How many are treating in-house with?
So when we wrote the business case was written for angioplasty in Dundee in 2004, and the ratio was about 2 to 1 at that time, and it's now 10 to 1. PCI to bypass for all comers, and that's mostly because we've expanded the acute work. But that's a statistic that I'd really like if it was published for every unit so that we could gauge things a bit more carefully. And whenever I speak to colleagues in Edinburgh and Glasgow to try and get a feel for are we around about the same ballpark, I think we are. But it's really much more about what's the right treatment for the right patient. If I had left mainstem disease now and want to go mountaineering or sailing in remote parts of the world, I would have to think very, very carefully about having a stent rather than a bypass, because for certain patterns of anatomy in certain patients, that freedom from repeat events is well worth the surgical morbidity.
So would you say then that there is still sufficient equipoise that at the end of the day it comes down to decisions in the room at the MDT?
Yes, absolutely. I think the difference between patients as individuals is much greater than the difference between techniques.
Okay. Any other questions? It's coming.
Just a very simple question. Are we still improving the stents? Is there still innovation going on there?
I think the margins for improvement are getting smaller. There was undoubtedly a big difference between the first generation stent that was used in the Syntax trial and the one used in Excel and in Noble. I think if we were to do the trial again, I think we might attenuate the differences a little bit, but there will still be an excess of myocardial infarction down the line after angioplasty, because you can't stent every single plaque that's going to rupture. If you try, it tends to be associated with worse outcomes than better outcomes.
I suppose one final comment that I always worry that if we do less and less of the cardiothoracic surgery, we'll have less skills, and then in the end, the outcomes will just get worse anyway. And then will it be a self-fulfilling prophecy? Do you think that could happen?
Yeah, but yes, it could happen, And yes, a lot of if cardiothoracic surgery were to be lost altogether, then there would be net harm that would be, people with mitral valve disease in particular, endocarditis, or dissection of the aorta and some trauma would lose out. But you're making decisions for population health numbers, and the harm that's bypass surgery is flattered by these trials because it doesn't measure the psychological and cognitive effects that when they affect people are truly life-changing as well.
Okay, thanks very much. Another round of applause for John.
Thanks, that was really interesting. Difficult, amazing, difficult decision making in these huge trials, and you think at the end of the day you end up with a
very subtle difference.
A subtle difference. You shrug your shoulders and you take your chances.
Yeah, well, I think persuading patients that bypass